Dr. Cibu Mathew, Professor and HOD, Department of Cardiology, Government Medical College, Thrissur. Dr. T.G. Jayakumar, Professor and HOD, Cardiology, Amala Institute of Medical Sciences, Thrissur. Dr. Karina Das, Professor of Cardiology, Government Medical College, Thrissur, and State Secretary, Indian Cardiological Society of India, Kerala Chapter. State leaders, Dr. Srivilasan, and and other members from other branches, and my dear colleagues. And special welcome to Dr. K. Mohanan, Vice Chancellor, Kerala University of Health Sciences, who has promised me join just few minutes back. And welcome you, Dr. Mohanan, sir. Good evening, and I welcome you all to this World Heart Days Observance CME 2020. IMA Thrissur organizing this CME with Thrissur Cardiac Club. Dr. P. Mohanan did all the homework for today's session, and thank you, sir, for your help, especially the way you accepted the request with utmost enthusiasm. Thank you very much, Dr. Mohanan. World Heart Day is celebrated every year on 29th September. Its aim is to reduce global mortality from non-communicable diseases by 25% before 2025. Cardiovascular diseases is accountable for nearly half of all NCD deaths, making it the world's #1 killer. People with CVD and its risk factors, including diabetes and hypertension, are more vulnerable to severe forms of coronavirus. Let us hear in detail from today's galaxy of eminent cardiologists who will enlighten us. Now I invite Dr. K. Mohanan, Vice Chancellor, Kerala University of Health Sciences, for his address, guest of honor address. Over to you, Dr. Mohanan.
Yeah. Thank you, Dr. Joy. Thank you very much. In fact, a few minutes ago, we were in another webinar wherein we were discussing the problems of adolescents. And a few hours ago, I was in yet another webinar where we were discussing the issues of the university. So now, as Indudharan has rightly said, this is a Zoom world. This is an unreal world, but we are fighting a real problem. President of IMA, Dr. Joy, Pavan Madhusudan, the Secretary of IMA, and Indudharan, the AMS President, and the incoming National President of Cardiological Society of India, and my great friend, Dr. P. Mohan, Dr. Geevar Zachariah, Dr. Govindan Unni, Dr. Cibu Mathew, Dr. Jayakumar, and Dr. Karina Das, and the eminent members of IMA Thrissur, and of course, our great friend, Dr. Srivilasan. On today, 29th, we are observing World Heart Day. And that is happening when the whole world is totally and completely disrupted due to COVID. And just we were listening to the Honorable Chief Minister, Kerala is on the verge of a second lockdown. But the message of the World Heart Day is use heart to beat cardiovascular deaths, cardiovascular disease. And in fact, all of us are using our not only heart, brain, or whatever in with us to decrease disease, decrease COVID, prevent COVID, or at least decrease the death from COVID. And even though all of us initially thought that COVID is essentially a respiratory disease, and with a little bit oxygen and few ventilators, all of us are going to survive. No, it affects every part of the body, and the major cause of death is cardiac issues. And therefore, we have to fight this disease with knowledge. And I'm so happy that IMA Thrissur has arranged the entire team of cardiologists, the eminent cardiologists in Thrissur are here, and they are going to save our heart with bombarding us with the knowledge. And with these few words, I request Dr. P. Mohan and team to start the program and save us from this disease. Thank you.
Thank you, Dr. Mohanan. Now, I invite Dr. Jain Chimmen for his Joint Secretary's address. Over to you, Dr. Jain Chimmen.
Thank you, President. It's a pleasure to see so many eminent cardiologists of Thrissur in front of us. It's a real pleasure. Thank you. I hope definitely it's going to be a real pleasure listening to all of this. We have an array of speakers lined up today. Meanwhile, since State Secretary, our own member, Dr. Gopikumar, is not there, I just want to warn our members that as Vice Chancellor VC said, Kerala is going to be in a big problem now. Already IMA has warned of the inevitability of the emergency situation that is prevailing in Kerala. Actually, instead of lockdown, we have all advised that we should have an emergency situation of health. Arogya emergency situation in the declares IMA we have been a little lax nowadays on enforcing the social distancing and also masking. So we have requested the state government to enforce that all the people are enforcing strict social distancing, and also the heavy penalties made to enforce masking of the public. That few words, I congratulate Dr. Joy for coming out with so many good webinars of interest to our members, and wish all success for today's webinar. Thank you.
Thank you very much, Dr. Jain Chimmen. Now I invite the brain of today's webinar, Dr. P. Mohanan, President-elect, National Cardiological Society of India, for his address. Over to you, Dr. Mohanan.
Thank you, Dr. Joy, for the opportunity. We are all really privileged to be part of this meeting. As everybody was mentioning, our VC also was mentioning the World Heart Day. We've been observing it for many years now. And every year they have a slogan. This year it was now beat the cardiovascular disease of yours, your society, and the entire, your family, your society. And unfortunately, this year, COVID has disrupted the entire life, and the importance of saving your life, protecting your heart has become the most important thing in the world. Now, the COVID has caused all of us to feel like as we are swimming in a turbulent water, struggling to reach the shore. Most of us are frightened of the rapidity of the infection. And it is understandable to get frightened because we are not trained in battlefield medicine. See, generally, all of us doctors, we don't need to risk our lives to save the patient's life. But you know what is happening. So many of our healthcare workers has sacrificed their life. But then at the same time, the current uncertainty also has been incredibly humbling. Possibly we clinicians were a little arrogant with all the knowledge and the innovations, technology. We possibly believed that we could defeat any disease. Not so. So I have my senior colleague, Dr. Geevar Zachariah, and then Unni, and the entire team from of Jay Kumar, Cibu, Mathew, and Karunadas to discuss with you the various aspects of COVID and heart during the next 1 hour or so. So I wish the meeting every success. Thank you.
Thank you, Dr. P. Mohanan, for your excellent words. Now I invite Dr. Unni R. Baby, AMS Convener, for the introduction of the moderator and the faculties. Over to you, Dr. Unni.
Thank you, sir. Good evening to everyone, and warm welcome to this World Heart Day or CME organized by IMA AMS and Cardiology Society of Thrissur. AMS has been organizing various meetings during this COVID time with speakers from worldwide, including US and UK. For World Heart Day, we have international speakers from Thrissur who will be speaking on various topics. The meeting will be moderated and introduced by none other than Dr. P. Mohanan. He's Director and Head of the Cardiology of Westport High Tech, and he's also the President-elect of Cardiological Society of India. I welcome you, sir, for this CME. He'll be talking on Introduction, COVID-19 and Heart. The next topic will be dealt by Dr. Geevar Zachariah. He is the chairman of Mother Heart Care, and he was a convener and chairman in various posts at national level. He'll be dealing with disappearing of MI during COVID. The next topic is COVID-19 and hypertension, the known and unknown. It will be dealt by Dr. Govindan Unni, sir, who is a professor and head of the Cardiology Department, Jubilee Mission Medical College, Thrissur. He has even recently published an international paper on COVID-19. So I welcome you, sir, for this conference and CME. The next topic will be how the COVID-19 will impact our heart. This will be a panel discussion, including the speakers and other doctors, cardiology, eminent cardiologists like Dr. Cibu Mathew, who is the head of the Department Cardiology at Government Medical College, Thrissur. Dr. Joy Kumar, who is a HOD Cardiology at MLA Medical College, Thrissur, and Dr. Karuna Das, who is a professor of cardiology at Government Medical College, Thrissur. I welcome you all the eminent speakers to this conference, and I welcome you all for this academic feast. Thank you.
Thank you. Thank you, Dr. Unni, for your introduction. Now I am handing over the whole procedure to Dr. P. Mohanan, the moderator of this session. Over to you, Dr. Mohanan.
Thank you, ma'am. As I have just already briefed you about the importance of COVID and cardiovascular system, our VG mentioned about the importance of the cardiac impact of COVID-19. And we have we found that 40% of COVID patients develop cardiovascular dysfunction. And we will touch upon each one of them in detail. And I will request our IMA delegates to interact with these erudite faculty, make use of the maximum benefits from the faculty. I will not stand in between the scientific program and my erudite speakers. First, we will have discussion by Dr. Govindan Unni about the importance of hypertension, how hypertension and COVID behaves. Now, COVID, when it happens in hypertensives, it has a higher mortality, and there was a lot of confusion regarding the use of antihypertensive drugs during COVID time. So, Unni, may I request you to start your proceedings?
Thank you, Mohan. Thank you, Mohan. I hope I am audible and my slides are also visible.
Yeah.
Yeah, you are audible.
Thank you. Thank you, Mohan, and thank you, IMA Thrissur, for giving me this opportunity. My topic, as you can see, is COVID-19 and hypertension. There are several things which are known and maybe even more things which are not known. Well, if you ask me who are the patients who are at the maximum risk of dying from coronavirus, there are two groups of people. Group number one is the elderly, as you can see, from a mortality of 0% in those under the age of 10. The mortality rises to 14.8% in those above the age of 8. And the important group are those with underlying underlying comorbidities, like cardiovascular disease. You can see the mortality is very high, followed by diabetes mellitus, chronic respiratory disease, hypertension, cancer, and you can see the difference in mortality with somebody who has no underlying comorbidities at all. Let me now come to hypertension and COVID-19. Basically, the problem in hypertension and COVID-19 has been the controversy with respect to RAAS blockers and the treatment of hypertension in COVID-19. If you look at the early reports from Wuhan, China, and the next country which was involved is Italy, Lombardy, Italy, it has been found even from the early reports that the morbidity and mortality of patients with COVID-19 are high if they have hypertension, coronary artery disease, diabetes mellitus, CKD, or obesity. It was also found that in the more severe the patient is, the severely ill hospitalized patient have higher rates of hypertension. The SARS-CoV-2 infects human cell via ACE2 receptor that acts on the renin-angiotensin-aldosterone system. Now remember, this ACE2 is different from the ACE that we talk about, the ACE inhibitors like captopril or lisinopril or ramipril. That ACE is different from this ACE2, which I'll come to later. So anyhow, the SARS-CoV-2 enters the human cells via ACE2 receptor that acts on the renin-angiotensin-aldosterone system and hence is a key regulator of blood pressure. And so there are discussions about the relationship between hypertension, the renin-angiotensin-aldosterone system, and the severity of COVID-19. If you look at the prevalence of hypertension overall in non-critically ill patients with COVID-19, it is just 4.5%. But if you look at the elderly patient, the prevalence rises to more than 30%. Approximately 50% of the US patients of hypertension are on RAAS inhibitors, and it may be slightly less, but still a good number of patients in India are also on RAAS inhibitors. Maybe the most frequently prescribed antihypertensive medication, even in India, are RAAS blockers. So the question is it the RAAS blockers and hypertension that is leading to the mortality in COVID-19 patients with hypertension? Or is it just that most of the patients are hypertensive, are elderly, and most of these patients are on RAAS inhibitors, and that is why they increase mortality? That question is probably one which has to be discussed in detail. Well, as I already said, there is overrepresentation of hypertension among critically ill patients with COVID-19. So the question we have to answer is, ACEIs and ARBs, that is the RAAS blockers, do they upregulate the ACE2 expression? Because as I already said, the SARS-CoV-2 virus enters the cells through ACE2 receptors. So if the ACEIs and ARBs increase the ACE2 receptors, obviously there will be more chances of COVID-19 infection, and there will be more severe COVID-19 infection also. If you look at animal studies, the results are very inconsistent. We really do not know whether RAAS inhibitors increase the ACE2 levels. And if you look at human data, unfortunately, there are not much human data also. But cross-sectional studies of patients exposed to long-term RAAS therapy show that plasma ACE2 activity is not higher in treated subjects. Let us now go into more depth into this coronavirus and the ACE2. The coronavirus has three proteins, the spike protein called S, the membrane protein called M, and the envelope protein or the E proteins, of which what is important to us is the spike protein or S protein. The infection starts when the viral surface protein or the S protein combines with the ACE2 receptor on the lungs or the alveolus. Now, this ACE2 is maximally represented in the lung, and so it is not surprising that COVID-19 has lung problems as the most important problem. It is also highly expressed in the heart, and so naturally you get a lot of people with myocarditis and even diseases like mimics myocardial infarction. It is also seen in intestinal epithelium. You have now enough number of patients with intestinal symptoms in COVID, vascular endothelium, and of course the kidneys also. The whole confusion came when there was a rapid response article published in the online BMJ saying that AC inhibitors could act as a potential risk factor for fatal COVID-19 by increasing the ACE2 receptors. And this was obviously quickly picked up by the lay press, and there was a lot of confusion among physicians and patients whether to take RAAS inhibitors or not. A word about the RAAS system before I go further as an introduction. As you know, RAAS system, the renin-angiotensin-aldosterone system, is a critical neurohormonal pathway that regulates BP and fluid balance. And the end product of this system is angiotensin 2, which is the most potent vasoconstrictor known, which is also have a central role in myocardial hypertrophy and fibrosis, inflammation, vascular remodeling, and atherosclerosis. So the end product of the RAAS system is not a good molecule. The ACE2, which we have been talking about now, through which the COVID-19 virus enters the human body, converts this angiotensin 2, which is a bad molecule, to angiotensin 1,7, which is a vasodilator, which in turn is a good molecule. So actually ACE2 is a good molecule because it converts angiotensin to angiotensin 1,7. It diminishes hence vasoconstriction, lung injury, inflammation, vascular permeability, myocardial injury mediated by the RAAS system, which means that ACE2 actually protects against acute lung injury. So the ACE2 is good as far as reduction in lung injury in SARS-CoV-19, as far as SARS-CoV-19 is concerned. But at the same time, as we already said, it increases the viral entry into the cells and so increases the viral load. So there is a confusion now of which is good and which is bad. As already said, the ACE2 receptor via its spike protein enters the human alveolus or any other cell. And as it goes inside the cell, the ACE2 receptors are destroyed. And so naturally, the number of ACE2 receptors come down, or there is down regulation of ACE2 receptors. So what happens is that there is accumulation of angiotensin 2, which I said is a bad molecule. So there is a local activation of the renin-angiotensin aldosterone system and results in lung injury, vasoconstriction, inflammation, and all the severe respiratory illness that is the hallmark of COVID-19. So again, to put you pictorially what I have already said, you have angiotensinogen, which is converted by renin to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by ACE, which is blocked by the ACE inhibitors. Remember, this is not ACE2, this is ACE. And then the angiotensin 2 acts on the AT2 receptor, AT1 receptor, leading to all these things: vasoconstriction, lung injury, vascular permeability, myocardial injury, and the ARBs act here at the level of angiotensin 2 receptor level. Now, what we are interested is in the ACE2, which converts both angiotensin 1 and angiotensin 2 to angiotensin 1,7 and 1,9, and that is ACE2, which is not blocked by eocaptopril or ramipril or lisinopril. It is not blocked by ACE inhibitors. It is ACE2. And so ACE2 is a good molecule, but unfortunately, it also leads to more virus coming into the body. So as you can see here, the ACE2 receptor gets attached to the virus, and the ACE2 and the virus gets inside the cell, and the ACE2 receptor is destroyed. So when the ACE2 receptor is not there, these conversions do not happen. Angiotensin 1 to 1,9 and angiotensin 2 to 1,7 do not happen. So there is excessive accumulation of angiotensin 2, which leads to all these bad things: acute lung injury, acute myocardial remodeling, vasoconstriction, increased vascular permeability, etc. So there are two things that happen to produce lung injury. One is the angiotensin 2 molecule, which can be prevented by giving ACI and ARB, and also by ACE2, which converts angiotensin 2 to angiotensin 1,7. But at the same time, increasing ACE2 leads to increasing viral load as more and more virus gets into the cell. So you can see there are two things that happen. Angiotensin 2 produces lung injury, ACE2 produces increased viral load and thus lung injury. Among the two, it has been found that actually angiotensin 2 produces more lung injury, and so ACE2 is actually not very bad as far as COVID pneumonia is concerned. This is a review article which we published on the impact of COVID-19 on the cardiovascular system. We reviewed the available reports and came to several conclusions, published in the Cardiovascular Drugs in Therapy. Now, currently, there is no compelling evidence that withdrawal of ACE or ARBs will lead to anything bad, will not affect the infection or impacts clinical outcome. So a patient with hypertension who is on a RAAS blocker like telmisartan or an ACEI like ramipril, there is no evidence that they should stop these drugs. Moreover, as you already know, in COVID-19, there is lots of myocardial infarction, myocarditis, cardiomyopathy, etc. And so actually, if you stop these drugs, if you interrupt these cardioactive medications, there may actually be more problems than solutions. So most of the peer-reviewed studies published so far has found that people who are on RAAS blockers, there is no higher level of infection, there is no greater severity of the disease, no increased mortality among patients with RAAS blockers. No studies, however, have addressed the safety of initiating RAAS blockers. So now we know that we should not stop RAAS blockers, But should we start RAAS in COVID patients to protect the lung and the heart? That's so far we really do not know. So most medical societies, whether it is the American College of Cardiology or the European Society of Cardiology, has only said that you continue RAAS blockers. Don't stop RAAS blockers, but they have not said that you should start RAAS blockers to prevent COVID-induced pneumonia. These are the various trials that have already been published with respect to RAAS blockers and COVID-19. And you can see that most of the outcomes are neutral. Whatever few studies that is positive is actually in favor of RAAS blockers. They show that there is lower rate of severe disease and there is reduction in all-cause mortality. But there are lots of trials still going on. These are the trials which are being continued. Patients are being recruited in several studies. We will have to wait the results of these studies before finally saying that RAAS inhibitors are not harmful. But as we now know, RAAS inhibitors are not harmful, and you should be continuing RAAS inhibitors in patients who are at risk of COVID-19 or who already have COVID-19. So my dear friends, let me conclude by saying that hypertension is an important comorbidity in COVID-19 patients. The presence of hypertension increases morbidity and mortality in these patients, though we are still not sure whether it is hypertension per se or it is because patients with hypertension are the elderly. Which is the cause of increased morbidity and mortality, we do not know. But presence of hypertension definitely indicates increased morbidity and mortality. As at present, there is no evidence that RAAS blockers either harm or benefit these patients. So guidelines say you continue RAAS blockers. Continue RAAS blockers in patients who are already on them. But at the same time, whether you should start RAAS blockers to protect their lung and heart is very questionable. We have to wait for more data before we start RAAS blockers in a patient who has COVID-19. In sick patients, of course, like in any other sick patient, one has to watch for hypotension. When we may have to stop these drugs, we have to watch for worsening renal function. When again, we may have to stop these drugs, especially if the potassium starts going. So stopping RAAS blockers in patients with COVID-19 depends on other situations, basically hypotension, worsening renal function, or hyperkalemia. With that, let me conclude. Thank you, MOHANAN, once again for giving me this opportunity. Thank you also, IMA, for giving me this opportunity. Thank you very much.
Thank you, Unni, for that excellent opener. And you just conveyed to the fact to everyone that a continuation of the ARBH inhibitor is the order of the day. One need not hesitate about whatever earlier theoretical speculation about the possible adverse effect of ARB during COVID time. We will take the discussion. I'm sure there will be plenty of questions after the panel discussion. And I look forward to the day when now you're seeing every day about the involvement of the confusion created by the progressive lung fibrosis in post-COVID scenario. And I wish the ARB decreases this fibrosis, and there will be a time when possibly we will be initiating ARB in COVID patients. Now coming to the next topic, and also thank you for sticking to the time. Now coming to the second topic on disappearing MIs. That's a very fascinating phenomena which the world over has been seeing. After the COVID started sometime in March or so, when it became more prominent, world over the number of hospitalization for acute myocardial infarction dwindled like anything. America reported 35% reduction. Spain reported 40% reduction. World over, the myocardial infarctions were not seen. So people wondered, what is happening? Is it because of the lockdown that MI patients are not coming? Then somebody speculated that, well, it may be the clean air which is causing lesser heart attack, or it may be the patient is stress-free, so lesser heart attack. Or maybe he is more concerned about his better diet. And we in India also, under the leadership of Dr. Geevar Zachariah, is our chairman of the Sub-Council of Cardiological Society for Cardiovascular Research. And under his leadership, we did a fantastic study of almost 200 hospitals all across India. And I welcome Dr. Geevar to talk about this very important topic of the quote unquote disappearing MI in COVID times? Geevar.
Oh, thank you. I'm not able to share my screen. I don't know. 1 minute. Share.
Joy, can somebody help?
I mean, share. There is a share screen in the.
You may have to permit. You may have to give some permission.
Oh, yeah.
Permission has already been given.
Okay.
I'm trying to allow.
A mouse താഴെ കൊണ്ടുപോകുമ്പോൾ share screen കാണാം.
അത് ക്ലിക്ക് ചെയ്തു. അത് ക്ലിക്ക് ചെയ്ത് അപ്പൊ അത് ഡെസ്ക്ടോപ്പ് വരുന്നില്ലല്ലോ. ഞാൻ എൻ്റെ സ്ക്രീൻ ഓൺ ചെയ്തിട്ടുണ്ട്. There is a problem.
Pawan, can you help me?
Screen sharing on ആണ് sir. ഞാൻ വേണമെങ്കിൽ ഒന്നും കൂടി ഒന്ന് റീസെറ്റ് ചെയ്യാം.
അത് റീസെറ്റ് ചെയ്തു.
അല്ലെങ്കിൽ make him a co-host. Pawan, can you make him a co-host?
അങ്ങനെ ചെയ്യാനുള്ള ഓപ്ഷൻ ഇല്ല സാർ നമ്മുടെ ഇതില് അതില്ല.
ഞാൻ എൻ്റെ പ്രസന്റേഷൻ ഓൺ ചെയ്ത് വെച്ചിട്ടുണ്ട്. ഷെയർ ചെയ്യുമ്പോൾ വരുന്നില്ല എന്ന് മാത്രമേ ഉള്ളൂ.
Pawan, ഒന്ന്
ചെയ്തു സാർ. ഷെയർ മാത്രം ക്ലിക്ക് ചെയ്താൽ മതി.
ഷെയർ ക്ലിക്ക് ചെയ്തു. അപ്പോ എനിക്ക് കിട്ടുന്ന സ്ക്രീൻ മൈക്രോസോഫ്റ്റ് പവർ പോയിന്റ് വേറെ എല്ലാം പുതിയ സ്ക്രീനുകളാണല്ലോ വരുന്നത്. ഷെയർ എനിക്ക് കിട്ടുന്ന സ്ക്രീനിൽ ഡെസ്ക്ടോപ്പ് 1, വൈറ്റ് ബോർഡ്, ഐഫോൺ അങ്ങനെ പറഞ്ഞിട്ടുള്ള കുറെ സാധനങ്ങളാണ് വരുന്നത്.
അതിനകത്ത് ഡെസ്ക്ടോപ്പ് കൊടുത്താൽ മതി.
അത് തന്നെ സാറിന്റെ സ്ക്രീൻ ഒന്ന് അതിൽ ഷെയർ എന്നുള്ളൊരു ബ്ലൂ കളറിലെ ഐക്കൺ കാണാം. അതിലൊന്ന് ക്ലിക്ക് ചെയ്താൽ മതി.
ഷെയർ ഓക്കെ.
ഷെയർ സ്ക്രീൻ കൊടുത്താൽ മതി സർ. ഷെയർ സ്ക്രീൻ കൊടുത്തു കഴിഞ്ഞാൽ അതിനകത്ത് ഷെയർ സ്ക്രീൻ കൊടുത്തു.
അല്ല ഇത്
VJ Paul is somebody else is sharing the screen. That is the problem. Somebody else is sharing the screen.
Dr. VJ Paul screen
sharing the screen. Please stop sharing.
വേറെ ഷെയർ ചെയ്യുന്നുണ്ട്. വേറെ ആര് ഷെയർ ചെയ്യുന്നുണ്ടോ?
That's what it is shown.
Okay.
സാർ ഷെയർ സ്ക്രീൻ കൊടുത്തു കഴിഞ്ഞിട്ട് സാറ് ഡെസ്ക്ടോപ്പ് എന്നുള്ള ഓപ്ഷൻ ക്ലിക്ക് ചെയ്താൽ മതി.
അത് ക്ലിക്ക് ചെയ്തപ്പോ അത് ക്ലിക്ക് ചെയ്തിട്ടുണ്ട്. Allow അതിൽ allow എന്ന് പറയുമ്പോ ഒരു ഓപ്പൺ സിസ്റ്റം പ്രിഫറൻസ് എന്നാണ് വരുന്നത്.
അന്ന് കൊടുക്കൂ സർ. ഓക്കേ. അത് പെർമിഷൻ ഡിനൈ ചെയ്തിട്ടുണ്ടാവും, അതുകൊണ്ടാണ്.
അത് ക്ലിക്ക് ചെയ്തോ. പെർമിഷൻ സാറ് ക്ലിക്ക് ചെയ്തോളൂ. ഓപ്പൺ സിസ്റ്റം പ്രിഫറൻസ് ഓപ്പൺ ആവട്ടെ.
ഇതിങ്ങനെ ഒരിക്കലും വരാറില്ലത്. ഞാനിതൊന്ന് ഓഫ് ചെയ്തിട്ട് ഒന്നുകൂടി നോക്കാം. ദിസ് ഈസ് എ വെരി ഇതുവരെ ഞാൻ ഐ എം ഫസ്റ്റ് മീറ്റ്. there is something happening. Share computer sound, share screen video, share. എൻ്റെ ഡെസ്ക്ടോപ്പിന്റെ അവിടെ ഒരു ക്വസ്റ്റ്യൻ മാർക്കാ വരണേ. Okay, I think we will have to discuss it without the slides. It's all right. Whiteboard, Microsoft PowerPoint unknown വരുന്നുണ്ട്. ഇത് ആദ്യമായിട്ടാണ് ഞാൻ ഇങ്ങനെ ഒരു പരിപാടി കാണുന്നത്.
ഷെയർ സ്ക്രീൻ എന്നുള്ള ഓപ്ഷൻ ഉണ്ടാവും സർ. ഷെയർ വൈറ്റ് ബോർഡിന് മുകളിലായിട്ട് ഷെയർ സ്ക്രീൻ ഉണ്ടാവും. അതൊന്ന് നോക്കൂ സർ.
ഒരു മിനിറ്റ്, ഞാൻ ഓഫ് ചെയ്തിട്ട് എൻഡ് ചെയ്ത ഇപ്പൊ ഷെയർ സ്ക്രീൻ ഞാൻ ക്ലിക്ക് ചെയ്തപ്പോ എനിക്കൊരു സ്ക്രീനാണ്. ബേസിക്, അഡ്വാൻസ്ഡ് ആൻഡ് ഫയൽസ്. പിന്നെ ഡെസ്ക്ടോപ്പ്, വൈറ്റ് ബോർഡ്, ഐഫോൺ എന്നൊക്കെ പറഞ്ഞിട്ടുള്ള ഇതാണ്.
അതിനകത്ത് ഡെസ്ക്ടോപ്പ് ഷെയർ ചെയ്തു സർ.
ഡെസ്ക്ടോപ്പ് ക്ലിക്ക് ചെയ്തിട്ട് ഷെയർ അടിച്ചാൽ മതി.
ഡെസ്ക്ടോപ്പ് ക്ലിക്ക് ചെയ്തു. അപ്പൊ എന്നിട്ട് ഷെയർ. ഓക്കെ, ഷെയർ അടിച്ചപ്പോ നത്തിങ് ഈസ് ഹാപ്പനിങ്. ഓപ്പൺ സിസ്റ്റം പ്രിഫറൻസ് എന്നാ ചോദിക്കുന്നത്.
അല്ല, ഉണ്ണിയും ഡിസ്കണക്ട് ചെയ്തിരുന്നോ സ്ക്രീൻ ഷെയർ?
ഞാൻ ഡിസ്കണക്ട് ചെയ്തിട്ടുണ്ട്. എന്റെ സ്ക്രീനല്ലോ ഷെയർ ചെയ്യണത്.
അല്ലല്ല, ഇടക്ക് ഉണ്ണിയുടെ പേര് വരുന്നു. അത് മറ്റേ ഉണ്ണിയായിരിക്കോ?
പവർ പോയിന്റ് അയച്ചു കൊടുത്താലും മതി. അല്ലെങ്കിൽ
ഇല്ല, കുഴപ്പമില്ല സാറ്. പ്രസന്റേഷൻ സ്റ്റാർട്ട് ചെയ്യും. ഇവിടുന്ന് കറക്റ്റ് ചെയ്യാൻ പറ്റുമോ എന്ന് നോക്കാം.
ഓക്കെ
സാറ് ടോക്ക് സ്റ്റാർട്ട് ചെയ്തോ.
ഡോക്ടർ പവൻ അതൊന്ന് മെയിൽ ചെയ്യാൻ പറഞ്ഞാൽ മതി. നമ്മളുടെ അവിടെ നിന്ന് IMA ഷെയർ ചെയ്താൽ മതി ആ സാധനം. അങ്ങനെയും ചെയ്യാൻ പറ്റും.
പവർ പോയിന്റ് ഒന്ന് മെയിൽ ചെയ്താലും മതി.
അത് ചെയ്താലോ, അതായിരിക്കും നല്ലതെന്ന് തോന്നുന്നു. ഒരു മിനിറ്റ്,
ഏതാ മെയിൽ ID ഏതാ?
പവന്റെ കൊടുക്ക്.
ജോയ് സാർ ഒന്ന് IMA മെയിൽ ID എന്ന് പറഞ്ഞു കൊടുക്കാമോ?
IMATSRbranch@gmail.com.
ഐ ഏതാണ് IMA?
IMA TSR branch
branch
@gmail.com. ഞാൻ ചാറ്റ് ബോക്സിൽ ഇട്ടുണ്ട്.
ഓക്കെ, വന്നിട്ടുണ്ട്. അത് ഞാൻ അയച്ചിട്ടുണ്ട്.
ഓക്കെ,
ഞാൻ നോക്കാം.
ഓക്കെ,
You can start and then play. By the time it will be okay.
അല്ലെങ്കിൽ അത് വരുമ്പോഴേക്കും അടുത്ത സ്പീക്കറെ വിളിച്ചാൽ നമുക്ക്.
Then there is a panel.
ഇനി പാനലാണ് അല്ലേ?
Without much of a problem. You can manage.
അല്ല, വരും. ഒരു മിനിറ്റ്, ഒരു സെക്കൻഡ്, ഒരു മിനിറ്റ് മതി. അവൻ വന്നണ്ട. പവൻ വരുന്നുണ്ട്.
ഇല്ല, സാർ സ്റ്റാർട്ട് ചെയ്യട്ടെ. ഞാൻ ശരിയാക്കാൻ പറ്റുമോ നോക്കാം.
Okay. So, I mean, the topic today, this World Heart Day is unlike any other that has come before. More than 33 million people are affected by COVID-19 all over the world, as on yesterday. And around 1 million people have died. In India itself, 6 million people are already affected and 1 lakh people have died. And you all know the impact of COVID-19 in Kerala. So the theme of World Heart Day is use heart to fight COVID. That is one of the themes. So the pandemic is actually creating a perfect storm for the heart. That is what the World Heart Day advertisements say. That people with COVID-19 and heart disease are among those with the highest risk for death and of developing severe conditions. Secondly, after the virus attacks, the heart might be adversely affected even in people without previous heart conditions, potentially resulting in long-term damage. And finally, fear of the virus has already led to sharp decline in hospital visits by heart patients for routine and emergency care. Theoretically, corona should increase acute myocardial infarction because any acute respiratory syndrome is associated with an acute myocardial infarction due to plaque rupture related to the inflammatory activation. So you would expect that more acute MI to occur in the COVID era. And secondly, COVID-19 increases the blood thrombogenicity because of the inflammatory response, and that itself should increase the acute myocardial infarction. And thirdly, the social isolation and decreased daily activity, sedentary lifestyle, and dietary changes during the COVID and its lockdown all should increase the atherothrombotic risk. And lastly, the damaging economic effects of the COVID increases the stress and also access to the drugs. So by all these accounts, one would expect an increase in an acute myocardial infarction in the COVID time. So, yes, now we have the slides now.
Yeah, you got the slide.
Okay, right, great. Okay, the world, okay, move next, okay, it's not moving. Okay, now, next one.
പവൻ സാറേ, ഞാൻ ഷെയർ ചെയ്യാം.
Okay.
സാർ ഫോൺ
So, but the first indication that instead of actually the MIs increasing in the COVID era, the New York Times actually published in February, March an article. Where have all the heart attacks gone? And except for treating COVID-19, many hospitals seems to be eerily quiet. That was the statement that New York Times did. And then there was a study published in New England Journal of Medicine. That's called California. There are 21 hospitals in the California region. They estimated the weekly admissions for acute myocardial infarction and then plotted against the graph of the COVID cases. You can see there are three graphs here. One is the blue line indicate the start of the number of COVID epidemic in California. It started from the February, the vertical line, I don't know whether you are seeing it. I'm sorry, I think. What they shown that at the time the COVID infection actually started rising from the February 26th March, till that point, from Jan 1 to March 3rd, the number of acute MI admissions parallel to the same in 2019 and 2020. There was no difference. However, when the COVID infection started to rise from March 1st onwards, the number of admissions for acute MI started to come down. So that by the middle of April, there was a huge difference between the acute MI admissions in 2019 versus 2020. So that was the California study. Next slide, next slide. Next one. Next one. So this was a study I was talking about, California study. The blue line is the COVID epidemic. Actually, the vertical line, the March 4, is the first reported death from COVID-19 in Northern California. And you look at the red line and yellow line, orange line, and indicate the number of admissions during 2020 and 2019. Yellow line is 2019 and the red line is 2020. And as you can see, once the number of COVID cases started to rise, the admissions for acute MI actually falls. Next slide. Next slide. Okay. And the same, and another 1 month later, there was a study from Italy. There are 50 hospitals, and the Italian Society of Cardiology did this study. And they found that they compared the same week in 2020 and the corresponding week in 2019. And they showed that acute myocardial infarction, considering STEMI and NSTEMI, was brought down to by 48.4% in Italy at that time. Next slide. And the mortality of acute myocardial infarction actually went up when compared to 2019, where the mortality was 2.8%, the mortality was 9.7%. So even though the number of acute MI admissions came down in 2020, the mortality actually increased in 2020. Next slide. So we decided at the Cardiological Society of India, MOHANAN is the president-elect, and I'm the Registry Data Council convener. We wanted to study in India what is happening, whether the same thing which is reported in Italy, Spain, Austria, US, and England, where the acute MI admissions have come down during the COVID era. We wanted to look what is the scenario in India. So we selected a period, March 15th to June 15th, 2020, and then we compared the number of admissions with acute MI in 2019. Next slide. And we selected all CSI Cardiological Society of India has 26 chapters. 22 chapters actually agreed to participate. And there were some places like Punjab and Chhattisgarh, where there's no chapter, they also participated. So ultimately, we had 198 hospitals all across India, from Tripura, Arunachal Pradesh to Gujarat, Ahmedabad, then Ludhiana, Delhi, Kerala, all the centers in South India. So it was a mammoth effort. Next slide. And this is what we found, that in 2019, the total admission during the period from 15th of March to 15th of June was 25,418. And in 2020, the total admissions were 16,414. And the total number of patients we actually evaluated is a huge 41,832. And we found that there's a 35.4% reduction in the acute MI admissions in hospitals across India. Next slide. And when we analyzed the chapter-wise, there was a difference. Some chapters like Mumbai, Delhi, Chennai, UP, Rajasthan, mostly chapters of states in North India, they showed a significant reduction in acute MI admission. For example, in Mumbai, the reduction in acute MI admission was 54.3%, and in Rajasthan, 44.8%, in Chennai, 53.2%, and Delhi, 53.6%. But look at the right-sided columns, Kerala, 8.6%, that was the difference in Kerala. And some of the Haryana, Indore, Andhra, the reduction in acute MI was less marked. So there was a heterogeneity in the reduction in acute MI admissions in this present study. Next slide. In Kerala, within the Kerala itself, there was a huge difference. For example, in Kasaragod, Wayanad, Kozhikode, we found that actually there is acute MI admissions have increased. Similarly, in Ankamali, Kolancheri, the acute MI admissions have increased. But in Thrissur and Palakkad and Kochi and Perindalmanna and Tiruvalla, there was a significant decrease in acute MI admissions. So Kerala did not behave uniformly, but overall in Kerala, there was only 8% decrease in acute MI admissions. Next slide. So summary of these findings were 35.54% reduction in acute MI admissions in India during COVID era compared to corresponding period in 2019. Heterogeneity among the Indian states. Some states significant fall in acute MI admissions, some did not. The trend for increase in in-hospital mortality was there. The in-hospital mortality was slightly higher, but that was not very significant. Next slide. And there was increased thrombolysis as a strategy for acute MI. There was a significant increase in thrombolysis. That was also expected because cardiologists were hesitant to do angioplasty, so they preferred thrombolysis during this period. And women and elderly are less likely to get admitted with acute MI in 2020, naturally, because probably they were forced to stay back even when they had acute myocardial infarction. And lastly, the smaller cities, the admission pattern did not change much. Actually, the decrease in acute MI admissions were more prominent in the larger hospitals, not in the smaller hospitals. Next slide. So why is the admission rate for ACS much lower than expected rather than higher as predicted? Next slide. Why acute MI are fewer, basically? That is the best question. Now, why less admissions in acute MI in the COVID era? One possibility is the fear of getting infected in the hospitals. That's a big issue. And that is what happened in the US and Italy, where the number of COVID cases actually parallel the reduction in the admission for acute MI. So they were afraid that whether they will get whether they will get infected in the hospital. So that COVID was rampant. The second possibility is the healthcare system itself is so overwhelmed by COVID, so that probably the mild cases of MI, probably they did not get attention. And the third possibility is the lockdown and the non-availability of transport. These were the three possibilities we considered. Next slide. But could it be due to true reduction in the incidence of acute MI? That was an intriguing possibility, whether all the three things which we discussed earlier could be methodical, logistical issues, but could there be a true reduction in the incidence of acute MI? Next slide. A paradoxical beneficial effect of social containment. You are leading a more relaxed lifestyle, sudden avoiding exercise, hectic daily activities, and even sports activities are known to trigger MI. The other possibility is the COVID MI patients may have an increased pain threshold. So you don't, even if you have a chest pain with MI, you may not recognize it. And then the last possibility is the beneficial effects of reduction in air pollution, which Dr. Mohanan has alluded to. Next slide. But this is interesting that air pollution has a relation to cardiovascular disease. Next slide. Next. In 34 studies, short-term PM 2.5, which is a measure of the air pollution, that air pollution increased the relative risk for acute myocardial infarction by 2.5% per 10 milligram per cubic millimeter square increase in the air pollution. Next slide. Next slide. And India is one of the worst air polluted region in the world. As you can see that in a scale of 0 to 80, India's air pollution rate satellite mapping is 75 to 80, where Australia and USA is around 12. Next slide. And the air quality index in India actually dropped considerably during this period. From 3rd March to 14th March itself, there was a significant drop in the air quality index. The poor air quality actually improved to better level. Satisfactory level, the green is good level, and satisfactory, it was been poor before the pre-lockdown, and after lockdown, it has improved. Next slide. The air pollution in major Indian cities and affects the Mumbai's, the air pollution level was, before that, it was very high, 20, it was 40 in 2017, 47 in 2018, and 36 points. So it has come down significantly by more than 50%. The same thing happened with Kolkata, Delhi, and Bangalore. So the air pollution level has considerably come down. Next slide. However, when we analyzed our data, we are now yet to analyze our data in relation to the air pollution level, which is we are doing it. We have collected information about weekly air pollution rates. There are 12 air pollution detecting stations in Kerala itself. There are altogether around 500 air pollution detecting stations under the pollution board in India. And that data is available, and we are trying to see whether the reduction in acute MI admissions in India is due to the air pollution levels. But what was apparent was this start, because actually looking at this, the week 1, week 2, week 3 of the study period when the lockdown actually started, the initial 8 weeks, look at the 8 weeks, week 8, up to the week 8, the reduction in the admission was very significant, 46, 49, 48%, 56%, and reached a peak of reduction of 52% in the week 6 or 7. But look at, as the lockdown started to be relaxed, when week 9, 10, 11, and 12, look at the figures now. The figures are coming down. Actually, even though the COVID cases, I listed the COVID cases are increasing from the 334. It was 6 at 6 weeks when the maximum reduction of acute MI admission, COVID case was only 16,000. But now it is more than 1 lakh, the 13th week, still the reduction in acute MI was only 14 or 15%. Showing that in India at least, it is the main driver for reduction of acute MI admission is the lockdown, not the COVID cases, probably not the air pollution level, probably not the other factors we mentioned, but purely because of the lockdown. That is because the CREATE registry has shown earlier that most Indians come to the hospitals by either public transport or private transport. Both were not available in the COVID time. And ambulance service in many Indian cities, very, very poor. And that is probably the most likely reason why we saw an acute MI admission decrease in India, all over India. Next slide. So it appears that in India, the reduction in acute MI admissions is driven by lack of availability of transport due to lockdown rather than fear of getting infected with COVID from hospitals. Next slide. The intriguing possibility of effect of reduction air pollution needs further investigations. Next slide. In Kerala, the weekly admissions, these are the weekly admissions number. Next slide. Next slide. So why Kerala is showing less reduction? Because Kerala, as we showed initially, only 8% reduction in the number of acute MI admissions. That is because of the good ambulance service. One is possibility is a good ambulance service. We are not much dependent upon the public or private transport for patients reaching the hospital. We have fairly good service. And that is why probably the admission rate did not come down much in Kerala. Kerala peaked the COVID cases very late. At the time of this study, number of COVID cases are very low. So that could be one reason. And third reason is air pollution in Kerala is not a problem, because when all the big cities in North India has a very high pollution, the Kerala has always recorded a very low air pollution rate. So that any difference in the air pollution which has happened after the lockdown, which are likely to be minimal. And last reason, which I think is the availability of facilities for acute cardiac care in smaller hospitals and smaller cities. Like Kolanjeri, they said that they have an increase in number of acute MI admissions, but that Kochi had a reduced number of acute MI admissions. Mainly because the people who are used to go to Kochi for acute MI, they started going to the smaller hospitals. Next slide. So whatever is the reason, it is important to tell our public that reaching hospital at the earliest is important in acute MI, and time is muscle. Thank you.
Thank you, Geevar, for that outstanding data, which possibly will be of great concern. I mean, great opportunity for us to showcase this fantastic data. This opened up. I'm sure there will be plenty of questions which we will take up later. But interestingly, this tell us two things. What I've seen in the other part of the world is there was an increasing incidences of out-of-hospital cardiac arrest. We have not taken that. So there were many people and now who develops heart attacks, remain in the hospital, develop complications. So the prediction is that we may see very many complicated MIs. That's one point. The other point is all these years, now we have been told that there are 9 risk factors for heart attack. Usual smoking, dyslipidemia, diabetes, hypertension, vagara, vagara, vagara. Now it opens up important thing like air pollution, which is getting its importance. I'm not saying we have absolute proof, but air pollution matters. Even in the United States recently, there was a re-emergence of coronary artery disease. All of us believe that, oh, US, the CAD, the coronary artery disease is coming down. It is not so. In the socio-economically weaker group, and also in the minorities, it is increasing. So these newer and newer risk factors are coming, and we may have to pay more attention to it. So that leaves it. This is the stage is set for our panel discussion. And as you know, gentlemen, I have a dream team of 5 eminent cardiologists. Dr. Cibu, who heads the Division of Cardiology from Medical College Thrissur. Dr. Jaykumar, who heads again Division of Cardiology at Amila Hospital Medical College. Karunadas, our very active Secretary of the Cardiological Society, Kerala chapter and professor there. And of course, our veterans, Unni and Geevar, are part of this program. Are you ready, folks? I suppose so. If I am allowed to screen, I will not show any slides. A program where we will just discuss amongst ourselves. So let me ask a question to Dr. Cibu. We discussed a little bit of it, but there will be some overlap. But what are the cardiovascular complications observed in COVID-19 patient, Cibu? If you can hear me.
I will unmute myself. Okay. Sir, am I audible?
Yeah.
Thank you, sir. Thank you, IMA, for giving me this opportunity to be with you today night. So, COVID, most often they are asymptomatic and they do not have any cardiovascular complications. But when they develop complications, cardiovascular complications is an important factor. And when they die, At least 40% they die because of cardiovascular complications. And only respiratory complication, respiratory failure is ahead of cardiovascular complications. And there can be different cardiovascular manifestations. The severe forms like hypertension, cardiac failure, acute myocardial infarction can occur, thrombosis and thromboembolism and problems related to that, arrhythmias. So many things can happen which can produce morbidity and mortality. So there are several pathological mechanisms, as Unni sir was telling. One is the inflammatory process. Another is the endothelial dysfunction. And third is an increased coagulopathy. The inflammatory process is supposed to be the most important thing. Now, there is a cytokine storm, excessive release of inflammatory cytokines, which can lead to organ dysfunction. This can lead to cardiac dysfunction. And the cytokine storm is one of the most important reasons for heart failure. Other reasons can be myocarditis, fulminant myocarditis, because the virus itself producing cardiac damage. Or it can be an endothelial dysfunction, which can produce a microvascular as well as macrovascular problem, a plaque rupture, acute MI, which is possible. A thrombosis. All this can produce cardiac failure. One important thing is a stress cardiomyopathy. You should understand that these patients, COVID patients, are extreme stress. They are isolated from their family, and stress cardiomyopathy is, we are probably maybe underestimating, and stress cardiomyopathy can produce cardiac failure. So cardiac failure is one important thing, and one of the commonest, one of the most important pathology is the cytokine storm or inflammatory process. Another thing is the increased coagulopathy. Because of some unknown reasons, there is an increased risk of thrombosis. And this can produce venous as well as arterial thrombosis. It can produce acute myocardial infarction, thromboembolism. And these patients can have problems related to thrombosis. Arrhythmias is an important problem, which can be because of the myocarditis or because of the drugs. Hydroxychloroquine, you know that people were using hydroxychloroquine for prophylaxis as well as for treatment. It can produce sudden, there is a fear of sudden cardiac death after taking hydroxychloroquine, especially those having long QTs or QT prolongation, arrhythmias. Arrhythmias can occur because of myocardial problems, myocarditis, AF, VT, all this can occur. So these are the cardiac complications which are expected. And acute myocardial infarction we expect to be higher, but surprisingly the incidence was lower. And one thing gave us, which I think another reason why acute myocardial infarction may be lower is also because the incidence of respiratory infection has come down. Our report says that the use of antibiotics and respiratory infection with the use of mask has come down. And certain studies have shown that there is 15 to 13 times relative risks with acute myocardial infarction with acute respiratory infection. Can it be a reduction in the other acute respiratory infection, which is producing a lesser incidence of acute myocardial infarction? We have to look into that also. So these are the common cardiovascular manifestations. But the most important thing is the cytokine storm or inflammatory response.
Thank you, Cibu. Now we have an entire gamut of cardiovascular complications caused by this deadly virus. We will discuss about it. I'm sure your theory that the inflammation has been important in the genesis of acute atherosclerotic vascular disease. We will discuss about it. Karunadas, is there? We know that underlying diseases causes higher mortality, and underlying cardiovascular disease is one of the real concerns. Can you just explore that particular point?
Okay, sir. Am I audible?
Yeah.
First of all, let me thank the IMA as well as Mohan sir for allowing me to be part of this panel discussion. Even in the previous SARS epidemic, as well as in this COVID epidemic, it is found that people with cardiovascular disease do badly. In this epidemic, whatever data is available till now, all over the world, if you look at the severely affected group of patients, that means patients who are on ventilator or who die, severely affected patients, around 20 to 25% of them have cardiovascular disease in one form or the other, apart from hypertension or diabetes. The data is consistent all over the world. While if you look at the other factors that increase the severity of the disease like obesity, It is reported more from America, but not from China. If you take hypertension, it is more in America, but not from China. But cardiovascular disease is consistent. 20% of the severely affected people do have cardiovascular disease. Is it possible that they are more susceptible? Well, the data says no. Everyone has the same susceptibility to get an infection, but they have a more severe form of the disease. The exact mechanism has not been elucidated, but various postulates, as Dr. Cibu put, as Dr. Geevar said, there is increased chances of coagulation, increased cytokine storm, inflammation, lot of fluctuations is happening in the body, and probably this worsens the cardiovascular disease per se. And there is a direct, probably an indirect interaction with the drugs, especially hydroxychloroquine as well as azithromycin, which prolong the QT. When given to cardiac patients, probably that is also contributing, but there is no solid data about this. So just to summarize, cardiovascular disease is bad. If a person develops COVID disease, you are likely to have a more severe disease. That's all, sir.
Thank you, Karnadasana. It is true that cardiovascular disease patient doesn't attract COVID disproportionately, but then once you get that, then your chances of having all sorts of complications are definitely more. Now we come to the next point. We heard from Geevar there may not be any gross decrease in myocardial infarction in Kerala on the instances of acute MI. But it's a real problem. Somebody during the COVID times comes with an ST elevation MI, Jagomar, in your hospital. So we have very many guidelines. What will be your management strategy in acute ST elevation MI in COVID time?
Okay. Hello, sir. Can you hear me?
Yeah, sure.
Okay. Thank you, sir. Thank you. Thanks, IMA, for inviting me for this talk. In a patient with a ST elevation MI and whose COVID status is unknown, what to do? So we know that any patient who is likely to get admitted due to any acute illness has to be considered as COVID positive until we get the results of an RT-PCR or TrueNat. So an ST elevation MI patient, if the status is unknown, should be considered as a positive patient till we get the results. Now, but the problem with the management of acute MI is that we cannot wait for the management to start, because we know the time is muscle and all. So we have to institute reperfusion therapy as early as possible. So we know the standard treatment of myocardial infarction is primary angioplasty. If the patient presents within 12 hours and if he is an eligible candidate, then the treatment of choice is primary angioplasty. But in a patient with COVID, or in this COVID era, the difference is that there is going to be some unavoidable delays, because we need to take the swab from the patient. We need to prepare the cath lab staff who will have to don the full PPE on, because we do all primary angioplasties with the full PPE. So all these things are going to take time. So now, normally in the pre-COVID era, we used to we used to have a criteria called a door to balloon time, which used to be 60 minutes. But in many countries, they have found that it is impossible to live up to these guidelines. So now the ESC has now stated that you can extend that time up to another 60 minutes more. So you can do primary angioplasty if it can be done within 120 minutes. So that is what we follow. So I will just briefly discuss what we follow in our hospital. So as soon as a patient comes with a ST elevation MI, so in the casualty itself, we do a primary echo just to see that there is the diagnosis, to confirm the diagnosis and to make sure that there are no other complications. And if the patient is in the category A or category B, then we take two swabs, one for the rapid antigen test and another for the TrueNat. And then the patient is directly shifted to cath lab. All the other management strategies like antiplatelets, anticoagulants, everything is the same. And we always offer primary angioplasty as the first choice. So in the cath lab, we have two labs. So we have set aside one lab exclusively for COVID patients or COVID suspect patients. So that lab has a separate entry and exit. So these patients don't come in contact with the other patients.
So the patient is taken to the cath lab. All staff members, all the nurses, the technicians, the doctors, everybody has to wear full PPE. And by this time, usually the rapid antigen test will come, and irrespective of the rapid antigen test result, whether it is positive or negative, we enforce that everybody wears full PPE, because you know that 30% of the patient of our rapid antigen test can be falsely negative. So we complete the procedure, and after completion, then again this patient will not be shifted to the regular ICU. We will be keeping him in a holding ICU, where all the COVID suspected patients are kept, and he will be monitored, and we will wait till the TrueNat result comes. Once the TrueNat result is available, if it is negative, then he goes to the regular ICU, and if it is positive, then he will go to the COVID ICU, which is an ICU exclusively for the COVID patients. So this is what we do. So in summary, the management of ST elevation MI in a COVID patient is not different from that of a non-COVID patient. Only thing is that every hospital should have some strategies to reduce the delay which is caused by the additional steps which has to be taken in this COVID era. So,
yeah, thank you, because now you have the advantage of having two labs, one which can be done. The ideal thing is catheter-based primary angioplasty. But then if now the problem is many of the labs may be having.
Then if there is only one lab, what can we do is we have to fumigate or sterilize the lab after each procedure.
And maybe the concept of thrombolysis, which we will discuss soon. And every ST elevation may not be possibly associated with a lesion in the coronary.
Correct. COVID can cause, there are several ST elevation MI mimics, what they call like Takotsubo cardiomyopathy, stress cardiomyopathy, or MI without an epicardial coronary block. These are all, they are all present in COVID, but they are actually generally rare. If the patient has typical symptoms and ST elevation MI, most likely that patient will be having an atherosclerotic disease and an occlusive disease. That's what we have seen.
And echo will be very valuable, Jaykumar, to distinguish between these pseudostomy cases with COVID, isn't it?
Yeah, many times, because some echo patterns are very suggestive, like an apical ballooning. Yes, correct, sir. You're right.
No, but then you are now you keep your echo machine in the emergency department.
Yeah, we have an echo machine in the emergency. It's basically a combined echo and ultrasound machine. So we'll do what is called a focus, or a focused echo, just to see the LV function and wall motion ability. That's all. We don't do a detailed echo because that is not recommended in COVID anyway.
True.
Yeah.
In many Jagamar, in many hospitals, during our survey, we also found that in many hospitals, even large hospitals, even with 2 or 3 labs, they now prefer to do thrombolyze first and then send for the lab evaluation and then do only rescue angioplasty or pharmacoinvasive angioplasty.
No, there is a problem. There is a major problem with the pharmacoinvasive therapy in India because most of the time what we use is the streptokinase. That is the agent we use it for thrombolysis, and we don't have any data on streptokinase when it is used in the pharmacoinvasive strategy. We don't know the results.
No, these hospitals using tenecteplase only.
Yeah, tenecteplase can be used. That is, the pharmacoinvasive therapy is almost as good as primary angioplasty. Then the problem is the cost of the therapy. The tenecteplase itself will cost about 30,000.
In our study we had 50% of the people who received thrombolysis all over India, 50% patients received tenecteplase.
30, around 40% will
40%.
Yeah, 40%.
That can be done.
So I think the use of tenecteplase have come up.
Has gone up.
There was actually a re-emergence of the concept of thrombolysis. Now, if you remember when China, after the Wuhan episode, the Chinese came out with the proposal that every MI patient, preferably they wanted.
That was the strategy.
That was the strategy, and that was followed by many. And only we are coming to the thrombolysis part. I will want to Dr. Govindan Unni. What about thrombolysis? Is it safe, or do you have any concern about thrombolysing patients with STEMI in COVID patients? Unni, are you around?
That is muted.
Can you unmute yourself?
Cibu, can you stop your sharing your screen?
I am doing it. I will stop it.
Because then you can see others.
Yeah.
Okay, I think Jayakumar has already talked about the role of PCI and thrombolysis. If you look at the various, thrombolysis is definitely safe, no doubt about that. Thrombolysis is very safe in patients with COVID. If you look across the world, actually experts in China, Iran, Palestine, and Jordan, that is what I found out. These 4 countries still recommend prioritizing thrombolytic treatment for most patients with either confirmed or unconfirmed COVID-19 status. Whereas developed countries like United States, Italy, Australia, and New Zealand recommend that existing primary PCI protocol for STEMI patients. Now, what happened is that in China, when Corona first came in Wuhan, they found that it is very difficult actually because the number of cath labs were less. And once you take to a cath lab, it has to be a dedicated cath lab. So because of these problems, they thought that the stoppage of pandemic is probably very, very important. And so they said that most patients, the first line of treatment should be thrombolysis. In fact, if you go by the CCPCC guideline, that is a Chinese guideline, which is published in the circulation, they have recommended thrombolysis as the preferred reperfusion strategy. And the only patients who they say should go for PCI are those patients with STEMI and hemodynamic or electrical instability, which means quite a good number of patients, the routine STEMI usually goes for thrombolysis. This, as I said, is basically because of this problem that they wanted to save their healthcare personnel, they wanted to reduce the cath lab contamination, and they wanted to reduce the quarantine also. But of course, as COVID came to United States, the SCI, the Society for Cardiovascular Interventions and Angiography, said that all PCI hospitals with adequate staffing, primary PCI is still preferred. So I think there are now 2 options. In situations where you cannot really have enough personnel, in situations where you do not have a designated cath lab only for COVID patients, thrombolysis is still the preferred treatment. But there are problems, as I already said. There may be STEMI mimickers like focal myocarditis or Takasabu syndrome, where if you lyse, you may create more problems. Then again, we know that even with tenective plays, quite a good number of patients do not get reperfused. And so you require either a rescue PCI or, as already said, a pharmacoinvasive strategy, which results in more prolonged hospitalization of the patient, more associated exposure to multiple healthcare providers, etc., etc. So basically, it depends, I think, on whether you have enough PPE kits for all people who are in the cath lab. If you have sufficient PPE kits, if you have sufficient cath labs which can be designated for COVID, then possibly still primary PCI is the treatment of choice. If you do not have that, better go for thrombolysis, and then maybe after thrombolysis you can think about that. So I think
very well said that the primary PCI, all of us know, is the preferred method. But as you said, the logistics may not permit us. That's why even the Cardiological Society of India position statement suggested that we know only in India, it's only some 12% or 15% cath labs they have more than one cath lab. So these are all the logistic reasons why people may prefer a pharmacoinvasive method. And it is absolutely fair enough. Geevar, the thrombosis has been a big issue in patients with COVID. Now, it's not the myocardial thrombosis alone. You get pulmonary embolism, you get peripheral arterial thrombosis. It's a thrombosis gutbud. So, how are we going to tackle these thrombosis in this COVID patient?
It is a COVID positive, as we said, there is a hyperinflammatory state and also thrombosis in pulmonary veins and pulmonary arterioles, and again prolonged bed rest and deep vein thrombosis. All these problems are there in COVID patients when they get an acute myocardial infarction. And secondly, the problem is the drug interaction, which are the drugs used for COVID, and the drugs used, antiplatelet drugs, have a lot of interactions. So you have to be very, very careful when choosing the drug when you are treating a patient with acute myocardial infarction and positive COVID. Now, aspirin is generally considered to be above board. No problem. It doesn't interact with any of the standard drugs which are used, like either chloroquine or with azithromycin, nothing, no reaction with that. So there is no problem with aspirin. The clopidogrel problem is mainly with when you are using lopinavir or the ritonavir, where then the metabolism of clopidogrel is inhibited, so that the activity of clopidogrel has come down. So it's not as efficacious as when you don't have COVID. So clopidogrel should be used with caution when you are using. But remdesivir has no problem, and the favipiravir no problem, and no interaction with the methylprednisolone, no interaction with the hydroxychloroquine. So clopidogrel, no use clopidogrel. Don't use clopidogrel if you are using lopinavir or ritonavir. Then about ticagrelor is a problem. Ticagrelor has contraindicated when you are using lopinavir or ritonavir, because it is a strong, very powerful inhibitor of the cytochrome P453 AF4 system, so that they are contraindicated, ticagrelor. And the vitamin K antagonist, they have interaction with azithromycin, the lopinavir, ritonavir, and all other antiviral. So it is recommended that when a patient is on an oral anticoagulant, either the VKA, vitamin K antagonist, or whether they are on the newer generation of anticoagulant, all are interact with all the antiviral drugs, lopinavir and ritonavir, so that the recommendation is, if the patient is already on an oral anticoagulant for AF or mechanical prosthetic valve, convert then into subcutaneous low molecular weight heparin, which is generally considered to be safe. So to summarize, in a patient with a positive, COVID positive, acute myocardial infarction, while using aspirin is safe, but ticagrelor with caution, clopidogrel with caution, prasugrel is okay, provided the indications of prasugrel is all right. And then vitamin K antagonist with caution, all the newer oral anticoagulants with caution, and when steroids are used, vitamin K antagonist is better avoided. So
the safest thing, it seems, that at least in hospitalized patient, either heparin or low molecular weight heparin, then you may consider.
No, antiplatelets are required, because the thrombocytopenia is not very common with COVID, but the prothrombin time is slightly prolonged in most patients. That is what I understand.
Okay. And then most of the patients with COVID have dyspnea. And as Cibu has mentioned, Karunadath also has mentioned, the chances of developing myocarditis is also there. So the concern of development of heart failure in a COVID patient is always in your back of your mind. So what will be your approach to identify a COVID patient with heart failure?
Is it
Karunadath?
Okay. Sir, as you said, dyspnea is a common symptom in COVID patients due to the lung involvement. And it could also indicate that the patient is either worsening of having a worsening of heart failure, or developing a new heart failure, which is also described as part of myocarditis or stress cardiomyopathy. When we look at the biomarkers are all minimally or mildly elevated in COVID infections. With the stress on the lung, there is stress on the right ventricle. And if you look at the BNP or the NT-proBNP, they show a mild elevation even without a true cardiac failure. So they may not be very helpful in a patient to rule out a heart involvement. But if the quantity is very high, then definitely it indicates an involvement of the heart and heart failure. The next best thing will be to do an echocardiogram. As already said, an echocardiogram can be done, and we can look at whether there is a definite reduction of the ejection fraction or a diastolic involvement. Jayakumar stressed this point that we should do a focused echo rather than going for all the parameters. Just look at the LV function, just look at the RWMA, so that the exposure is minimal. The other investigations are rather not very useful, like MRI, to see whether there is heart failure. So predominantly a focused echo will help us to tell whether patient is developing heart failure or not.
But it is, as you said, it is important to distinguish whether a patient with dyspnea in COVID patient has an underlying myocardial dysfunction. And as you said, echo is a very close investigation, and we should be extremely careful in doing the echo. There are guidelines for suggesting how best the safety measures one has to take when doing an echo.
What is the value of CT scan in dyspnea in acute MI in COVID era?
Any take us for that?
Karnadas.
Cibu or Karnadas, you can say.
Sir, the CT scan is can help you to see whether there is lung involvement, but probably it will not help you to say that there is cardiac involvement.
It can rule out pulmonary embolism.
Yeah.
It can diagnose the lung involvement, and probably that should be a part of that investigation of a dyspneic patient.
It is not a mandatory investigation.
Yeah.
It is not a mandatory.
Not a mandatory, but I think it will help.
Yeah, it will. Yeah. And I was mentioning about, I was asking Jayakumar about the how are the mechanical support that we can give. Now we have seen recently our SPB was on ECMO for quite number of days. Unfortunately, we lost him. So there are instances where we have to use mechanical support to COVID patients. Can you just elaborate on that?
Yeah. Yes, sir. Hello. So, hello, can you hear me, sir?
Yeah.
So ECMO is basically considered as the last resort in cardiopulmonary support, because many patients they at some stage will develop end-stage lung disease, or they develop severe myocarditis resulting in severe LV dysfunction and very low cardiac output. Then they won't respond to any kind of drugs. Then ECMO is the last resort. So basically, the indications for ECMO in a COVID patient include severe respiratory distress, not responding to the full ventilatory support with the prompt ventilation, everything. If the patient is still not responding, or if the patient has severe cardiac dysfunction causing severe refractory hypotension, not responding to any of the standard inotropes or any other measures. So these are generally the indications for ECMO. And some patients may not be suitable for ECMO, like patients in whom anticoagulants are contraindicated, like a patient with active bleeding or so. And age more than 65 to 70 years, generally these patients are not offered echo. Actually, in the Kerala guidelines, they say more than 70 is a relative contraindication for echo. And also patients with the severe peripheral vascular disease, then you cannot cannulate echo, do cannulation. So there are basically... Yes, sir.
Jayakumar, what about in people with normal myocardial function and preserved blood pressure?
I'm coming to that. So basically, we have two types of ECMO. One is called veno-venous ECMO, and the other is called veno-arteriovenous ECMO. So as Geevar sir was pointing out, there will be one group of patients who have only respiratory dysfunction, only lung dysfunction with a preserved cardiac function. So their BP is normal or with maintained with very little support, but their oxygenation is very poor. In such patients, we can use what is called a VV ECMO or veno-venous ECMO. What is done is you take out the blood from the venous side, from the femoral vein, and then oxygenate the blood, and then give it back to the right atrium through a jugular cannula. And so then the blood goes through the pulmonary circulation and then goes to the systemic circulation. So the oxygenation is maintained. There is no hemodynamic support. There is no blood pressure support, but it's only for lung failure. Generally, this type of, if the patient needs only a veno-venous ECMO, then the prognosis is generally good, because there is a recent Lancet study where they studied about 100 patients. The survival was almost 75% for patients who required only veno-venous ECMO. But there is another group of patients who have both combined lung as well as cardiac dysfunction. So these patients will need both respiratory as well as hemodynamic support. So in that situation, we use what is called a arteriovenous ECMO. Here, what we do is we take out the blood from the venous side. We take the desaturated blood from the venous side, from the femoral vein, and then oxygenate it outside the body, and then push it into the arterial side. So the whole oxygenation part as well as the cardiac output part will be taken care of by the ECMO machine. But unfortunately, there are only very small series of this kind of ECMO used in COVID, but the survival has been very, very poor. Like out of 10 patients, probably only 1 or 2 will survive from a arteriovenous ECMO. So that has been because basically not because it's a problem with the ECMO, but because these patients generally have end-stage disease, so they may not respond to any form of treatment. So
Jagumar, one of the interesting observations that has come up is that one of the supposedly explanation for the hypoxemia has been a pulmonary vasculature dilatation. So the transit becomes very fast. There is no time for the blood to get sufficient oxygenation.
Yes.
So if people are contemplating about using how to reduce boundary vascular dilatation. So a very interesting thought process are coming up. I sincerely hope that somebody will come out with something.
Jagumar, but right now in Thrissur, I mean, if you want an ECMO,
actually, we have done for non-COVID patients, but for COVID patients, we till now we didn't have any serious patient till now.
Or you get the machine
but it's
equipment
available.
from Kochi?
We don't have it in Thrissur,
on-site.
Yeah, we can bring it from some other city because they have a few rotating ECMO machines in the country. So if it is required, they will bring it and we can.
You have used it in one of that myocarditis case.
Yes,
and
one young female with a myocarditis, actually an allergic myocarditis, refractory to all measures. Then that patient recovered without any complications.
That is a veno-arterial.
That is a veno-arterial. So it is possible, but only thing is that we will have to inform them in advance. Like they need about 24 hours time to bring the machine and.
And Cibu, I mean, that will come to a very serious point of healthcare workers' safety. I mentioned it initially that this is a situation where the doctors' lives are sometimes has to be sacrificed. So what you are seeing, you both are seeing at Medical College Thrissur, a lot of cases of COVID. And what are your advices to the healthcare workers, especially doctors, who are attending to these COVID patients?
Well, as you said, we have to prevent the infection at any cost. The number of doctors being affected and the death is alarmingly high. So the important thing is to prevent infection is a clear personal protective equipment and clear safety measures. So every patient, you have to think that that patient can be potentially infectious. So you have to get a history, whether the patient is having any symptoms of COVID, any epidemiological data or epidemiological link that the patient may be having COVID. In that patient, you have to be all the more careful. But as the number of cases are increasing, we have to consider that all patients may be potentially positive. So as soon as the patient comes, you have a quick assessment. And as Jagumar said, time is muscle. We can't waste time. Acute myocardial infarction, you have to treat immediately. So take a sample for rapid antigen test and at the same time, RT-PCR or TrueNAT, and shift the patient to a hold area where that patient is not allowed to mix with other patients and where you see the patient with full PPE, and at that time you treat. So two things which will reduce infection is your PPE and the time during which you are in contact with the patient. So reduce the time you are in contact with the patient. So minimum contact with the patient, minimum infection, and open space, minimum infection. So probably thrombolysis has an advantage there because thrombolysis, the minimum contact time, and that can be done in an open space. Whereas cath lab, it is a long contact time, multiple people are affected. And probably many of our cath labs don't have that pressurized system where the air as well as the virus can be pushed out. So if you are using a cath lab, you have to use a minimum contact time, minimum number of personnel in the cath lab, all personal protective equipment, and a pressurized system so that the air can go out. And personal protective equipment, another point is that when you are doing a cath procedure, you need radiation protection equipment also. With radiation protection equipment, to wear the PP outside the radiation skirt, it is actually extremely difficult. So you have to have a customized personal protection equipment for COVID. You can stitch accordingly. So that also may be important. And regarding echo machines can act as a format for transmission. So if you do not care the machine properly, the keyboard or the probe can be a format for transmission. So as far as possible, keep the probes and the keyboard covered, disinfect the probes in the recommended manner, and use echo sparingly only for the focused ultrasound. So keep all the machines, minimum machines in the cath lab, minimum exposure, reduce the number of the time of exposure, and do personal protection equipment as far as possible, and treat all patients as COVID positive.
Yeah, I mean, our salute to those healthcare workers who have sacrificed their life. And we know, I don't know, Cibu, this was from the WhatsApp University. I saw that the usual death rate is case fatality is 1.7%. When a healthcare worker gets it, it's 17%. I don't know. Is it right?
I don't know. I don't know.
Cibu, is it now even treadmill test? Probably it is not better to not to do it. Is it?
It is absolutely better not to advise.
It is better to not to do it. We stopped doing treadmill from the first day of lockdown, and only in absolutely necessary cases we do. All the windows open with the patient also wearing N95 mask, patient wearing a face shield. We do it, and that too spacing. And also
no stethoscope also.
Stethoscope we use sparingly, but we use with
regularly.
Breath holding technique.
I'm not using it now.
Breath holding
that
technique.
is the easiest way, because you come very close to the patient.
But sir, those patients coming with some symptoms, we cannot do echo in all patients. So I have picked up mitral stenosis in 3 or 4 patients by auscultation in the last 1 month. So,
our clinical skill has improved because of COVID.
No, sir. I just do the protective equipment, and then when I go to the patient, I just hold the breath for 1 minute or half a minute, and then oscillate and come back. That is my method.
Whether that is effective or not, but you may inadvertently take a deep breath also.
that is also possible.
That is true. I think Unni, the surgeons are the more the smarter lot. They went into a hibernation during COVID time. No puns intended. But do you think, is there any harm in advising somebody to undergo CABG during the COVID time?
In patients who are COVID-19 positive, forget about CABG patients, even other surgeries, it has been found that the mortality is high. Not only in patients who are positive for COVID-19, I read some data somewhere that if somebody turns positive for COVID within 28 days after the surgery, which means negative during the surgery, but turns positive within the next 28 days, even their mortality is very high. So obviously, CABG, especially elective CABG, or for that matter, elective procedure, is better postponed in patients who are positive for COVID. Now, after COVID, when will you do the surgery is a big question. I think we still do not have any answer, because just because COVID is negative does not mean that the patient is out of danger. Again, as you said regarding SP Balasubramanian, he was COVID negative for almost a month before he died. So I think we really do not know after COVID-19 when exactly the patient should go for his surgery. I think we will have to wait for more data till then. But preferably, elective surgeries at least are better postponed. But of course, there has to be individualization. A patient with a left main disease or a patient with an ongoing chest pain, you can't do anything. One has to take the risk and go ahead. So I think it has to be individualized, but in general, better to defer the surgery.
Absolutely, absolutely. Geevar, we are coming to the end of our
Hello,
panel.
sir. Can I ask a doubt, please?
We are finishing in 2 minutes, and then you can come back. We are every question will be answered. Don't worry.
Okay,
Don't worry. Geevar, the last question. No, you touched on this point about, especially about the acute MI patient refusing to come. What about the chronic patients? Our patients who are wanting to see us, and how do you see these days? Are you using telemedicine or the digital systems to help you?
No, I am not personally. I am not very comfortable with telemedicine. I see patients, but I tell all my patients that because if there is no emergency, continue taking medicine and avoid as far as possible all elective stable patient regular checkups can be postponed to another period. So I ask the patient, instead of 3 months visit or 4 months visit, make them 6 months visit or even 1 year visit. So all the chronic patients, probably they need not. And secondly, hospital visits should be avoided. But we also at the same time, we should tell that when you get an acute myocardial infarction or an heart failure, this is the time we in the hospital is taking all care to avoid cross infection with COVID for you, reassure them and ask them to come to the hospital if there's a problem. But otherwise, chronic stable coronary heart disease or heart disease patients, I tend to tell them telephonic, that patient telephonic advice is okay. Telephone, email, investigation, I ask them to check their BP and tell me what the BP, that is all. Close to face-to-face contact with the stable patient probably can be reduced or avoided.
Thank you. I mean, we have Sharmila. Sharmila, you had a question. Please ask it.
Yes, sir. What I wanted to know was that recently there has been a spurt of discussions as a few apparently healthy young people succumb to death while engaged in strenuous sports activity, which makes me wonder, do sports activities increase the risk of cardiovascular problems?
Who is taking it up? Geevar?
There is actually any physical, excessive physical activity, there's a very small risk of triggering an acute cardiac event. That is there always. So whenever you are planning to undertake a fairly rigorous physical activity, I think it is better to always get your basic investigations done. And especially if you are past your middle age, I would recommend that you do all the echo, treadmill, and then even coronary artery calcium score before taking up the rigorous sports. Otherwise, if you are doing it for years together, say 20, 30 years, you have been playing a particular sports, and you are unlikely to do an excessive activity, then I don't think that there is any extra risk for this patient. What is your general feeling, Mohanan?
I mean, and basically, even though there were some reports of a excessive troponin release after an intense exercise, but as you said, now, so there are people who develop sudden cardiac death, or most of them have some underlying disease, a hypertrophic cardiomyopathy or an occult coronary artery disease. So these are the guys who develop these, especially when somebody want to initiate into a high intensity activity.
Sometimes we overdo also. For example, I remember P.T. Usha coming to Sri Chitra Tirunal in 1980s or 70s. She had few ventricular premature beats, and the professor of cardiology said, no more sports activity. And if she didn't obey him, and
she was wise enough.
She was wise enough. So sometimes our advice is also not very proper.
Okay. Unni, you want to say something?
You very rightly, as I would say, is that, as you very rightly said, most of the deaths after exertion is due to an underlying disease. Some may be hypertrophic cardiomyopathy, or maybe some arrhythmias like Brugada, or some long or short QT syndrome, or something like that. Dying in a otherwise normal person during exercise is not very common. So I think that should not be a disincentive for starting exercise. Then of course the other thing is that is unaccustomed exercise. As you said, if you really regularly do some exercise, and if you continue to do that exercise, chances of sudden cardiac death, I think, are very, very meager. Only when you do something unaccustomed, then of course that possibility is there.
But you should have a risk assessment.
Yeah,
that I think it should be there. A proper risk assessment should be there before undertaking vigorous exercise. Moderate intensity exercise, there is absolutely no problem. When you are talking about vigorous intensity exercise, I think
marathon running or that sort of
running, or even a competitive sports.
Even like shuttle, something like shuttle has been.
Yes, sir. When you are undertaking a vigorous exercise like shuttle also, I think it is safe to, you have to make sure that you don't have, apparently normal people does not mean that they may have a plaque of 50% narrowing in a coronary artery, and it can rupture and it can produce an acute myocardial infarction. So it is better to assess your risk properly.
People, especially doctors, are hesitant. That is the problem. Now doctors feel that, well, I can manage to do it. That's the problem. I mean, but we have touched it. It is almost 1 hour plus.
Sir, one doubt, sir.
Yeah,
Thank
Dr.
you, sir.
Yeah, sir. Just a doubt. So for COVID-19 patients, there has been a sudden, collapse and death has been reported in many people. So would the panel recommend ecospirin for a COVID positive patient to avoid the thromboembolism?
Recommendation is anticoagulation. After severe COVID, when they are discharged, they are at risk of thromboembolic events, and aspirin is not enough to reduce the venous thromboembolism. Proper anticoagulation is needed. The government of Kerala has recommended apixaban as 5 milligram BD for 2 weeks after severe COVID, after stopping enoxaparin.
That is for enoxaparin, right? So that is at the state level.
That is not enoxaparin, apixaban.
No, post enoxaparin. After once you give the enoxaparin at the time of admission. For those patients, I think the state guidelines has been recommended.
That is in severe COVID and less severe COVID. There is a risk of thromboembolism in such patients. That is why. So such patients, you have to give anticoagulation. That is, I was stating one statement. Second, aspirin may not prevent the venous thromboembolism. Only anticoagulation can prevent venous thromboembolism.
Karunadas, do you recommend statin in COVID patient? Do you think statin will be of any value?
There have been some studies, sir, saying that increased cholesterol levels increase the entry of the virus into the cell. And if you reduce the cholesterol, this is going to be beneficial. And statins may be beneficial. But as of now, statins are used for the other indications, the regular indications, not when a patient becomes COVID positive, we give them statins.
I don't see anything in the chat box. We have about 58 people hanging around. Thank you very much for your continuing participation. Is there any other thing my erudite panel want to touch upon?
There is a question in the chat box. Where do we do coronary calcium score in Thrissur?
Cibu, you can take it up. Coronary calcium in Thrissur.
Sir, I think it can be done in most centers where CT scan is available. Coronary calcium score is not a tough thing.
I regularly send patients. I think Dr. Balachandran, the radiologist in Jubilee, regularly does it. And it costs only 3,000 rupees. It probably lasts a procedure of 10 minutes, very little radiation. And I think all cardiologists and doctors should, because if your coronary artery calcium score is 0, your risk of developing an event after 10 years is so negligible that I think doctors should take an example. Is it much better than doing a treadmill test? That is what Dr. Chandrasekharan has been repeatedly saying. So it is an underused modality. So if there is a message, my message is do coronary artery calcium score, call Dr. Balachandran.
Basically, the reason why people were hesitating was it was costing higher amount. Now they have realized that
only 3,000 rupees, 10-minute affair. There's no need to wait. It's very simple and radiation is very low.
Any more, Joy? Any more questions?
No more questions.
Okay. I think that comes to the end of the session. Over to you. You are back to IMA.
Thank you, Dr. Mohanan.